So thank you so much. Oh, thank you so much, Esther. And again, welcome to this ECHO presentation. We're delighted to have you here. I just want to inform and just give everybody the same understanding of what our learning objectives are for today. So by the end of this session, we hope that you as a participant would be able to recognize the impact of essential conversations on the quality of life of people living with a serious life-threatening diagnosis. A second learning objective is identifying opportunities for initiating essential conversations with clients, families, community members, and in various settings, including healthcare settings. And the third objective is to explore the roles of community and health systems in promoting essential conversations. And essential conversations, as we're saying, is anything and everything that has to do with living and working and caring for someone with a serious life-threatening diagnosis. To help us get a sense of who is with us today, Esther is going to pop in a poll in the chat now, and we would really love to have your answers to the following two questions. Number one is, how would you describe yourself? Are you a healthcare professional or a community member? And those are broad categories we recognize. The second would be, let us know your current level on today's topic. Are you familiar? Are you not at all knowledgeable? Are you somewhat knowledgeable? Or consider yourself very knowledgeable around essential conversations? So we'll just pop that quiz in for a moment. And I'm not seeing the response. Esther, if you can just give us a quick summary, or Kathleen, a quick summary of who's in our audience today, that would be awesome.
Yeah, okay. We just have like 80 percentage of people that have taken
Okay.
And right now, just be showing the results. And I think right now you can see my screen.
Perfect.
Yeah.
Okay. So recognizing today we have a great diverse audience, probably from various disciplines and various roles and lots of backgrounds represented in this room, of different knowledge levels, very knowledgeable and somewhat knowledgeable around essential conversations. I'm hoping that you will find some learnings that will apply to yourself and the role that you work in. So I'm going to just ask, even though we just asked you what your professional status is if you would take your professional hat off for just one moment as we move to the next slide, around matters for you. So when it comes to your personal health and your personal care, and we were to ask you, what is important to you? What matters most to you? I'm going to 4 statements here I'm going to read. And while I read them, I'd like you to identify just for yourself in the order of 1 to 4, with 1 being the most important and 4 being the least, if you would. What matters most to you? What is of highest value? What matters most to you? To keep your sense of humor, to have a doctor who knows me as a whole person, not being a burden to my family, not being connected to machines. So go ahead and maybe just sketch on your own paper or order for yourself what is most important for you. So once you've done that, if you'd be so kind to just drop your number sequence in the chat. Perhaps it's 2341, perhaps it's 1432. What is your combination of priorities? And just throw them in the chat for just a minute.
Melody, do you want people to list it from the top to the bottom?
Nope, whatever the order is for you. So, oh, from top to bottom, I guess so. So if keeping your sense of humor is number 3, you would go 3, 1, 2, 4, whatever it is. Does that make sense? That's right. Yeah, 1, 3, 2, 4, etc., etc. Just give you a second to do that. Thank you for sharing. I'm going to ask you one more time. The next slide what matters most to you. And do the same exercise, rating it 1 to 4 in priority to you. What matters most to you? To be kept clean, to have my family with me, to be free from pain, or to be able to talk about what death means. Go ahead and ponder that for a moment. And if you're so brave, once again, if you would put your number sequence or what matters most to you in the chat in this set. Thank you so much for sharing, everyone, as they're popping in. What we've discovered is, as I and many others do this exercise, we've discovered probably that it's difficult to make choices. And depending on where you are in your life or health or a disease progression or a trajectory of illness, these numbers and these matters might change for you in your priority. For instance, if right now as a healthy person, I would say, well, actually, it doesn't matter to me if I don't know my healthcare provider, he doesn't know me or she doesn't know me as a whole person. That's okay because I'm good with this. But if perhaps I was suffering in a serious illness with a lot of pain, I may say number 1 would be a really important priority, to be free from pain and to be kept clean, because dignity and what I look like matters most. One of the things that we've discovered, of course, is that this changes for everyone, and whether our demographic background or cultural background or just simply our personal preferences, this influences what kind of healthcare and personal care matters are important to the client and to the patient. And doing so, some of these questions begin the process of helping a person evaluate and assess and even talk about their family, with their family members and their loved ones, what really matters most. So just with this little bit of an introduction, I want to invite Kathleen now to take us into the next section of our conversation that we're going to have with Joe today.
Yeah, so just wanted to greet everybody, welcome. And I'm hoping that all of you have watched these videos. There's 4 of them. And I'm just going to summarize each one, and then we're going to go into breakout rooms and just discuss our reactions to them and sort of thoughts and implications for our daily lives and our daily work. So when I created these videos, they are a conglomeration of true stories. So I've had a few comments that, oh, it seems really harsh or unrealistic, but actually these are true events that have happened to people. So it's a conglomerate. So it's not one story that's true entirely, but a conglomerate of true stories. So in the first story about Joe, he has a serious illness that was diagnosed quite a while ago. He doesn't want to go to the hospital, doesn't want to have CPR, and doesn't want a breathing tube. He wants to die at home with his friend Peter and his cat nearby. He hasn't talked to anyone about what matters most to him and what his wishes would be if his health declines in the future. So when he has a healthcare crisis, he gets exactly what he did not want. And then the second one, and then we'll go into breakout rooms to talk about both stories together. So in this scenario, same people, same situation, but the difference is that Joe did talk to the person who knows him, people that knew him the best. So Peter, as well as his nurse practitioner, which was his primary care provider. He did legal documentation to appoint Peter as his substitute decision maker. He filled out the forms for no CPR and expected death at home. So when he has a crisis, he gets exactly what he did want. So we're going to break into small groups now. And how many people do we have online?
Let's say about
Pardon?
11 of us.
Okay. Do you want to just do 2 groups then?
Okay.
And we're going to paste these questions into the chat within the small groups. So you can just choose 2 to start with, which ones are you have the most to say, and we'll give 10 minutes. So if you answer all 4, that's even better. So how did you feel after Joe's first story? That's the one where he didn't have the conversations and got what he did not want. And what was the impact of essential conversations on Joe's quality of his life and the quality of his death? Where were the opportunities in the story, whether they were capitalized on or not? And then who in the story could have initiated the conversations? So go ahead, Esther, and put people into the groups.
There should be a pop-up on your screen, directing you to the room you've been assigned to.
We're going to go on and talk about Peter's story a little bit, but as I'm summarizing it, if you wanted to put into the chat anything that really stood out in your small group discussion, things that you'd like to share with the whole group, and we'll have a larger group discussion after we talk about Peter's story particularly. So go ahead and put into the chat anything that kind of stood out to you. Okay, so moving on to Peter's story. So Peter is Joe's friend, and he has his essential conversations with his family and his healthcare provider. He writes down his values and wishes and beliefs. So he goes into the healthcare system at a specialist office in particular. And although he's ready to have these conversations, the healthcare professionals and the system aren't ready to have the conversations. So he ends up feeling unheard and overwhelmed at the end of it, because the conversation kind of delves into treatment plans and everything before really talking about what his goals are. And then in comparison, in the second story, Peter's story with essential conversations, the system as well as the individual healthcare providers are ready to receive his advanced care planning information and what he's thought about already. Everyone in the story knows their role. Documentation has a specific place to live in the patient chart, and the whole team acknowledges what matters most to him. And so they design the care plan around these things. So we're going to go into breakout rooms again, but I'm just wondering, because neither of us were in those discussions. So I'm just wondering if it's worthwhile going into breakout rooms, or because we're fairly small, if we should have it as a larger discussion. If you wanted to do your reactions and do a, let's see, a thumbs up for if you want to stay in the larger group, and a thumbs down if you want to go into small groups. Okay, larger group looks like. You can put it in the chat too if you'd rather. Okay. Okay, why don't we just stay in a larger group? Okay, so here's the question. So similar to the first ones. How did you feel after the first Peter story, when he took his advanced care plan, but the healthcare system wasn't ready? You can put it in the chat, or you can raise your hand. Okay, thank you, Greg. So creating the spaces to have the conversation is key in normalizing it. Thank you. Did this story ring true for people in your own experience, or with as a healthcare professional, or as a patient or a family member? Yeah, so feeling sad. Thank you, Carrie. And Renuka, I'm guessing you're saying yes, it does ring true. So what was the impact of having those essential conversations on Peter's experience? So thank you, Belinda. I see resonates with some experiences with healthcare providers. Yeah, placing their values on your experience. I used to work as a manager in a specialist area, and I would deal with kind of patient complaints. And a complaint that was very frequent was that people felt like when they came to the specialist office that they were put on this train of treatment, and everything became so overwhelming in terms of what their plan was and their daily schedule. And there never really was a chance to talk about, do I want to get on this train at all? It was just, they felt like it was this train. And a couple of people actually used that exact language. So it definitely happens. And you're saying, Greg, yeah, having the conversations, yeah, opens up more possibilities, the space and the opportunity to speak. And we know from research that patients and families expect healthcare providers to bring it up. And conversely, healthcare providers often feel afraid or uncomfortable to have the conversation. So if both sides are wanting to have it, think it's important, but no one starts the conversation, of course, there's a big impact. Okay, why don't we move on to the next part? So into the chat, who are the people that can initiate the essential conversation? So in terms of healthcare professionals, who do you think is appropriate in terms of discipline, like physicians, occupational therapists? Who do you think can initiate these conversations, both as healthcare professionals or as community members? And just sort of brainstorm everybody you can think of into the chat. Thanks, Carrie. So we've got nurses, doctors, spiritual health practitioners, social workers, ... So yeah, lots of different options there. Family doctor. How about in the community? Who in the community could initiate these conversations, or kind of in the general public? Thanks, Belinda. So family, friends, peers, neighbors, healthcare professionals. Thanks, Greg. Anyone who's involved in aspects of care that impact longevity and quality of life can open it up. Yeah. Family doctor, nurses, clergy, spiritual leader. Yeah, other support workers. Thank you. And Carrie's saying spouse, family members, faith leaders. Yeah. That's great. Thank you. And yeah, support groups, end of life doulas. Yeah, thanks, Greg. Okay, so where can these conversations take place? And thanks, Belinda, for your comment here. Even if it's not their place, they can bring it to someone's attention. It's really true. Often what we find, we've done surveys with people that have had training on how to have the conversations with people. And what they say is one of the reasons they don't do it, even though they know how, is because they don't feel like they have permission or they're not allowed. So that's exactly what you're saying there, Belinda, that it's not their place. Okay, so where can the conversations take place? Where in the healthcare system, like what sort of care sectors, and then where, what types of community organizations could promote these? Melody, do you want to share just some examples of community organizations that have done advanced care planning work?
Hi there, sure. So you're asking community organizations that have facilitated. Well, I can tell you that we have trained many hospice organizations across British Columbia, and more recently we are working with senior organizations or organizations that support seniors, disease supporting specialist organizations. We do have faith leaders. So what we have done is work with their leadership or their volunteers to train them to become facilitators, which really means equipping and giving tools for starting a conversation. So the very little snippet that we did this morning is one way to start a conversation. And probably each of those items could be a conversation on their own. What we have discovered, of course, is that the more tools we have and the the more that we as individuals who are having these conversations actually do this, we normalize the conversation, demystify just this fear around end of life, or even the words palliative care, or the words that are like, oh, I'm not dying, am I? But just sometimes flipping it even to say, what does quality of life look like? What matters to you is a complete flip of, now I'm sick, what should I be doing? So if we talk about quality of life, what we have discovered in our communities, that's also an open door for people to take down a barrier or one of those fear factors that is covering them, saying, oh, this is really important. I've had a conversation with someone who said, it's really important for me to, if I'm not well, my caregiver and my family know I want my toes painted. Sorry, this is a feminine side, but I want toenails that are still painted because that's what I do. And I need my lipstick on in the morning if I'm having anyone around me. So it's a simple thing that could be around dignity. It could be around care. It could be around pain management. But what we know is the more we talk about it, our community organizations have been doing that as well. Maybe I rambled too long about that. Encouragement that anybody, anywhere, anytime can do the conversation and say what matters most to you.
Yeah, I just flipped it to the slide.
Yeah.
Does anyone disagree with this sort of idea that they can happen everywhere, that they can be initiated by anyone? Does anyone have a disagreement with that? Because I know we've talked to lots of people who do have disagreement with that idea.
Can I just talk and say, typing in
Yeah,
the
please
chat?
do, Carrie.
I
Thanks.
just think it's really important if anyone does feel like they have the relationship with that person to bring up these important matters, that there be a lot of sensitivity to that person and what they want and what's important to them. What are their values? Because sometimes people can try to impose their own, oh, this is what I would want, and think that that's obviously what the other person would want.
Right.
So there needs to be a great deal of sensitivity and some skill in bringing up these things. I agree, like making it just more possible or more comfortable for people to bring it up. It's important, but there also really needs to be that sensitivity.
Thank you so much. Someone had their hand up, I saw, but then I lost it. Was it Kyla? Kyla Morrison, I think. Did you have your hand up?
I'm just looking in the chat to the comment from Belinda. Thank you. It depends on culture and cannot necessarily be a conversation you jump in without consent. And we absolutely agree that cultural sensitivity, faith practices, beliefs and faith practices may greatly influence and direct even speaking around these matters. So very good comment. Thank you. Autonomy, independence of the person. Yeah.
We did a project with First Nations elders where we asked them about the conversation, the serious illness conversation guide that we use with healthcare providers. And one of their main recommendations was sort of what people are already saying. Don't jump into this conversation if you don't have any relationship with the person. And of course, that would be true for people of all cultures. And also ask permission to have this conversation. I was talking with my daughter the other day, and I said, I'm about to ask you a question that has to do with if I was in a serious accident. Are you okay if I ask you that question right now? Or will it upset you? So even just that, that simple sort of preparing people for something that could cause them upset, or maybe it's not good timing.
So the other thing, I guess, when we speak around conversations that matter is we recognize that each of the roles that we have in relationships with either family members or patients or clients, the center's work is really around advocating and helping to push essential conversations upstream. So sometimes from the perspective of a public health portfolio, it's around just giving people language to normalize a conversation and recognizing then that when there is a trajectory of an illness or a new diagnosis that's happened, that changes everything in who may have the conversations, and just allowing the individual to come to their own space to be wanting or willing to talk about, what's just changed in my life. So we look at the span of essential conversations, and just really place it according to where the individual is at. I guess that's where some of my comments have come from, but we look at this as the span of helping people have these conversations and normalizing it so that when they're in a place of need with healthcare providers and family around essential conversations and emergencies, that there's a space to do that.
So we just wanted to have a conversation about how do you think we could link together conversations that are happening in community with the conversations that happen in the healthcare system? We've got both groups represented here, so I'm just curious, what ideas would you have? Because often it's two separate things, and that's what we were trying to illustrate with the videos, that ideally both, you know, would come together. So what do people think? Greg, do you want to go ahead and unmute and speak? Because I know you were saying earlier that end-of-life doulas do this for a living, so it'd be great to hear your perspective.
Well, we kind of throw ourselves out there as a as a fulcrum to facilitate all of these kind of interactions. And so I know that in situations where communication is, you know, kind of the essence of things, death doulas or end-of-life doulas have, you know, kind of by nature of the title, you know, have this kind of built-in authority to say, hey, I'm a death doula. What do you want to talk about? And I think that having someone in this, you know, with one foot in each world is a good place to start, because facilitating the conversation is key, and knowing when to, when to inject this or to bring up this is quite often an experiential thing and not necessarily something that can be taught in a course. And so I think that that's, you know, like if we're talking about conversations, having someone whose role it is to facilitate these things, you know, gives us a place to go to. Like right now, if you're sick, you know, if it's serious, you go to a hospital, or you make an appointment with your doctor, or, you know, talk to your pharmacist about something minor. We don't have that same setup for people. Well, we do have the setup is kind of there, but there's no starting point. Like this is what all the questions are about, is like, where can you start these conversations? Well, having a person who's the target of that, you know, like has that on their back is a good place to start. I hate to sound like I'm plugging what I do, but it's kind of, that's the situation we find ourselves in, because we start with people from new, people with children who are just, newly starting their lives together, and start them thinking about it at that point and saying, here's let's do the plan well guide together, and, start these conversations and start normalizing. And so, to break the ice and to normalize it, we have to have something set up for that.
Thanks, Greg. So how do you find that the families that you work with, how does the communication with, say, their physician or when they go into acute care, what we might say is the healthcare system, how does that go in terms of, information flow?
That depends a lot on the system, because, again, you're dealing with people that are functioning in a way where their primary goal is to, statedly is, to prevent death, and, in as much as possible, to avoid that particular part of our life. And so there's a lot invested in saving. And so, and if people have kind of just bought into that aspect of it and not the holistic aspect of patient care, then it can be difficult. But I think now more and more, as more people from other cultures are coming into the system, I think these conversations are becoming more a little more natural in the system part of it, rather than the community side of things. So I think it's getting better, but people need to know that there are they're supported in these conversations as well. So I think it's true for doctors and medical professionals and everybody.
Thank you so much, Greg. What do others think about ways that we could promote and enhance these conversations, increase the number of them and the quality of them? What other ideas do you have, or what have you done that has worked? Okay, I'm gonna move on to the next slide. If you're all gonna be quiet, then I'm gonna be quiet too. Okay, Melody.
The
you're up.
extrovert in the group, so.
No, it's great. Thank you.
I think there's lots of things we can do, but I am going to encourage and challenge you each with a takeaway. And we want to encourage you to write down at least one action that you, not your organization, not the boss or your collective colleague team. What is one action that you will do in the next 2 weeks to promote or enhance an essential conversation? There's no boundaries on this. It could be a family, it could be a specific client, it could be anyone. It could be any action. The reason we're asking you to do this is because we all recognize it's really important. And I know that when in several family losses in this past year, this is one of the things that we keep talking about is, so what would you like? What's important? Who matters? Who would you like to have here? There's so many forms of an action or a conversation. So just want to encourage you that perhaps it's a nugget or an individual you may not even be aware of yet, but what is one takeaway from this conversation that you can employ into your own practice or life next 2 weeks? And I'm asking you to write it down. Maybe it's a sticky note, you're going to smack it on the computer or the mirror. And why did we do all of this? Well, because if you're on this call, like we all are, we all have a desire that people who are affected by serious illnesses have the best possible quality of life, supported by care that reflects their goals, their values, and their wishes. So that's what the BC Centre for Palliative Care does, but that's something that we are passionate about and hope that you can also do this too. So an action and a conversation so that indeed quality care is something that everyone can have. To that end, I want to share with you that the BC Centre is here to help you start and continue the work that you are doing, the great and essential work of essential conversations in your community and in your practices and your settings where you are. The BC Centre has many resources. You can jump on our website and you click to the tab bar that says resources, but specifically around advanced care planning or ACP. You can jump to resources ACP. We have a menu there that explains advanced care planning, and one of the key things we're really happy to make available for you is the resources that are downloadable, and you can filter them according to a resource and a language group that you're hoping to reach. We recognize we don't have the world here, but we are pleased to say we have 4 specific language adaptations for Punjabi speaking, Hindi speaking community members, as well as resources in simplified and traditional Chinese. So we hope that you'll take a look at that. Everything is accessible and downloadable. We just ask that you distribute that. If you are using it in a public space, is to give the credit there, but everything that you have is available at your fingertips there. Please share the conversation with many. You may or may not know, but every year, April 16th is Advanced Care Planning Day, which is next month. The BC Centre is pleased to once again, after 8 years, compile what we call a campaign toolkit, which is for organizations, healthcare providers, and systems to be able to use and to share the important message of advanced care planning. And the theme this year is a really powerful one. It's a continuation of last year, which is, if not you, who? Imagine not being able to speak for yourself in a healthcare emergency. Who would you choose to speak for you? This is a really powerful theme, and I again want to encourage you to jump onto our webpage there. We have a campaign specific webpage. We have outlined for you a toolkit, which include a really large assortment of digital assets. There's some digital assets in each of the 3 or 4 other languages. There's also a number of news stories, including healthcare providers who are advocating and have seen the effects and the impact of having an ACP, or for those who have not had the advanced care planning conversation. So there's a number of stories of our healthcare providers and other individuals. Please take a look, please share and promote, and please go ahead and make this as much a passion as message that we can encourage you in your organization as well. Beyond the public health scope, the next slide, please. Kathleen, would you share the resources for healthcare providers and educators?
Yeah, so we have, you know about ECHO since you're here. So we have other ECHO sessions with lots of different audiences. One that we have that's related to essential conversations particularly is, can't remember the exact title, but it's serious illness conversations for healthcare providers. So we do have that ongoing support. We also have online modules for healthcare providers about cultural safety in advanced care planning conversations. On our website, we have a number of different adapted guides. One that we adapted ourselves that I mentioned with First Nations Health Authority is the one in the middle of the slide here, which includes asking permission, more about bringing in family members and that sort of thing. And there's also guides that are specific for substitute decision makers, for people who are structurally vulnerable, pediatrics. We have all different languages, as well as one that was a brief version that was created during COVID that could be used. We're also working with academic institutions. So right now, it's really exciting that every physician that that graduates from UBC Medical School has had training on how to have these conversations. And 10 out of the 13 nursing schools will have this into their program as well by this fall. So, and we're also working with OT programs and pharmacy and social work and other ones just to kind of spread the love. And we also have another online module that's specifically around serious illness conversation. And this code is up on your screen that you can scan, and we will also send it out with the resources in our email afterwards. And it has a complete list of all of the resources that are available from the center around conversations, as well as palliative care provision. And then I believe we're going to have a poll come up. And this is sort of a pre-post of the first one. So I think, Esther, you're going to launch that one?
All done.
Okay, thank you. So we're asking about if your knowledge has increased, and then did attending the ECHO help you learn about support for people with a life-limiting illness from other organizations. So it looks like 100% did this. So your knowledge has increased somewhat was 4 out of 6 people, and then it increased a lot was 2 out of 6 people. So that's great. It increased somewhat at least, which is great. And then, sorry, I can't, oh yeah, and then attending ECHO helping us learn. 50% said slightly and 50% said a lot. So great. Thank you. And Melody, I'll let you speak to these ones.
Sure. So thank you for participating with us. Just a couple of other things we want to share with you. In the upcoming months, we are preparing with exuberant excitement for October the 4th this fall. The second biannual Altogether Symposium that the BC Centre for Palliative Care is hosting, entitled Nurturing Partnerships and Reimagining Palliative Care. This is an opportunity for our healthcare administrators, volunteers, community leaders, healthcare providers, researchers, frontline workers, international and national experts to join together in a dialogue and active engagement around palliative care and the compassion communities to improve and reimagine palliative care. We have an opportunity here we'd like to share for you, which is submitting a call for presentation, or abstracts as we would call it. We're calling them presentations. And we invite healthcare providers, palliative care leaders and educators, researchers, organizations, and volunteers to submit a presentation proposal. The categories for submission, there are 2 of them. One is learning and results, and the second one is ideas and inspiration. By that, we mean they don't necessarily have to be all successful. We want also the learnings and the results of something that may have been thriving, and perhaps the results weren't what we anticipated, but there's learnings to be shared there. So there are 2 categories. Come and engage on October the 4th. If you as an organization are presenting and are selected, we do have a free registration. It is downtown Vancouver, and I invite you to jump onto our website, our main website. There'll be a link there. You can jump onto the event for more information around the presentation proposals, and our submission deadline is April the 30th, so 6 weeks away. Thank you. And then as we're closing, Palliative Care Echo Project is a project established as a 5-year national initiative that is cultivating communities of practice and establishing continuous professional development among healthcare providers across Canada who care for patients with life-limiting illnesses. And you're free to jump on and look at echopalliative.com for their website to see all the echoes that are being hosted across the country. And at this time, we just want to say thank you very much for attending and joining us today. The Palliative Care Echo Project is supported by a financial contribution from Health Canada, and the production of this presentation is made possible through the financial contributions from Health Canada. The views expressed here do not necessarily express the views of Health Canada.
I just have a question in the chat from Rose Melody. Is there a template for submission of abstract?
Yes. Yes, there is. And actually, Rose, it's very thoroughly laid out. So if you jump on the webpage and you'll see submissions, there'll be all the guidelines for submissions. There's a template there that you can populate. It even allows it that if you're not quite done and you need to walk away and come back, it won't lose all your work. And your submission comes straight to us, and we will acknowledge it. And by June, we will be making the decisions and letting all the presenters know upon acceptance of their presentation.
Yeah, and then there's information in the chat here about our next session. It's actually quite nicely related to this one, is about exploring the role and impact of advanced care planning on patient, family, and caregiver grief and bereavement. And it's a crossover of this altogether and the grief and bereavement literacy. So that should be a really well-attended session and very interesting conversation. Okay, so we're going to close off now. And thank you so much for your time and your input and for joining us today.
Thank you so much, everyone. Have a great week.
Thank you, everyone.
Yeah.
Have a good one.
Thanks.